Thanks, Sean, and again, thanks to Claudio for the opportunity. As these are my disclosures, as you'll see from this title about patient selection indications, there's a fair amount of overlap with the next topic which Sean is going to give. But when you think about what clinicians need to do for making decisions for renal support in the ICU, you have both these elements to consider. Why is dialysis being offered, the timeliness, what modality, how much, and then an implementation strategy of how you actually make that happen. What I will cover is just this aspect, even though there is a significant sort of overlap between this and the next topic, which Sean will cover, so I'll try and stay within the constraints of this area. When you think about how we make that decision, we are almost always looking at patient characteristics and then bridging the gap of deciding whether or not therapy is needed or not needed based upon whatever we term as our indication strategy. And in essence, when you look at the question of why is dialysis being offered, there are two broad components that one considers. What's the patient need, coupled with a consideration, will the patient benefit from what you're going to offer in terms of dialysis versus whatever harm there might be potentially from the therapy itself or from not offering dialysis. So both those elements are the basic hallmarks of the decision. And when you think about this aspect, we are in three categories defining when RRT is required, whether it's emergent to life-threatening, when it's urgent, which I would term a rescue therapy, or elective, which is driven by goals of care. And on the other hand, the benefit versus harm consideration requires a thought process: should you withhold dialysis? Or if you do offer it, is it under the constraints of a trial? Or do you actually withdraw it early enough once you've started it? So these sort of are the framework, and what I'll try and do is walk you through some of the conceptual and the evidence behind why we do what we do. So just to put this back in perspective, you're looking at patient characteristics, indications, and therapy, and usually what we are doing is starting very quickly if there is an emergent or life-threatening situation. But more often than not, we are offering CRRT or IHD or any form of RRT mostly as an urgent or a rescue therapy, depending upon how quickly you are called if you're a nephrologist, or how quickly are you able to mobilize things if you're an intensivist. And then it's uncommon or relatively infrequent that elective therapy is offered in goals of care, depending upon what the situation is. And now this continuum of going from elective to urgent to emergent indications therefore becomes a norm of our daily lives and practice. This is an old slide from many years ago, but I just use it here to emphasize the fact that the terminology in terms of thinking about this is support, because you are distinguishing the RRT in this situation from that offered in ESRD. As you can see, the outcomes and the opportunities are different. In addition, your timing of intervention and therefore the indications may be somewhat different, as you can see here. But broadly then, if you look at the life-threatening indications that we all generally agree on for starting RRT are listed here, we also aim to utilize RRT for solute control, fluid or regulation of acid-base and electrolyte status, and then all these other indications are grouped under renal support categories itself. But a more important concept to keep in mind is that every patient in the ICU, as much as we can see, have the opportunity to change their characteristics fairly dynamically, and therefore the change in the severity of illness is quite common, so therapeutic modalities need to support this function. So one side of the equation is when you think about the therapeutic potential of any RRT, you can look at the targets on this side, but you can also see how best to achieve those targets requires some finessing of how the technology is utilized. And this gets into basically opportunities of which modalities you might use to make sure that you are able to achieve these targets. In general, we focus only on the upper two targets. We rarely are focusing our therapies to accommodate these biological effects, but as you can see that this is an area which is emerging and people are thinking more about. So now to focus on the central theme of this talk, which was basically how do you link indications to a patient selection process, I'll go through the broader constructs overall. So here are the traditional indications that we currently practice on. This is what we teach our colleagues, we teach our fellows, it's in medical textbooks, and these have been derived over years of experience, but as I'll show you in a moment, they are not necessarily the only ways that we should think about this. In fact, in the absence of any other definite evidence, these are the guidelines which have been put forth by K. Digo and are generally followed by most people. I think that one of the things to ask is, do we use these indications in current practice? And this is a very nice article from Sean's group published a few years ago where they looked at 6 ICUs at 3 different hospitals and looked at the patients who received RRT. And notice here is that this is the general characteristics of these patients, and almost about 80% of these patients received RRT when they were in the failure stage overall, and about 28% of these patients had been worsening in the stage of the rifle stage at the time that they got RRT. But what's more important here is that the prevalence of these various factors here, so oliguria and anuria were quite common in this aspect, and you can see that there is a significant association with mortality in these groups and also in the post-heart RRT length of stay in this setting. Similar criteria we used in almost all the studies, and I just show you one from the renal study from Rinaldo Bellomo, same criteria used. In fact, these have been the criteria which have been used in the most recent studies, which also I'll mention in just a moment. A similar observational study from a convenient sample of 11 ICUs. You could see that the serum creatinine was fairly high, and the SOFA score was high, and 64% failed the stage 3. And what you can see here is, here's the hospital admission scores. And you can notice that at admission, about 33% of these patients had stage 3. But by the time they start initiated CRT, 64%. So almost a doubling of these patients going from where they were in a lower stage to a higher stage. Please keep that in mind, because I think this is a key element that we need to consider when we are looking at patients and the indications overall. And in the same study here is, at the time that these patients were taken into place, these patients had metabolic acidosis, oligoanuria, peripheral edema, hyperkalemia, and the frequency of these elements here for traditional indications or clinician-reported indications were quite high. But in general, most of these people have more than one indication. So one could think of it in a different way and say is, we are prone to wait for more than one indication to occur before we offer RRT. And the time we wait for that offers the opportunity both for improvement, but also offers the opportunity for deterioration. And that's sort of a key balancing act that we have to think about overall. We have done a similar study with our registry, which was published in CJASN last year, and this is looking at patients from 9 centers in developed countries and 5 centers in emerging countries. And again, when you look at the distribution here of the developed versus emerging countries, not too different with respect to the timing overall. However, with respect to the maximum stage of AKI, you could see that the developed countries versus the emerging countries had higher stage of later elements. And what we found was that in this group, the average 23% of the patients required RRT and was started about a day after, But more importantly, in the developed countries, they were less often treated with dialysis and started dialysis after AKI diagnosis much later than in the emerging countries. So we, when we have access to dialysis, have the available technology, tend to wait. And that, I think, is a universal element which emerges from most of the studies that you look at observational data. And I'll come back to why that, to my mind, is an important criterion for us to keep in mind. So one of the things which one must ask is, where did these indications come from, and what's the evidence behind them? And when I started looking for that evidence, I found that there isn't a clear-cut demonstration that these indications are clearly what we need to focus on. So one study which has been published was looking at about 18,000 patients in an ICU database, the MIMIC database, which is from Boston. And in this group, 10,000 patients developed AKI, and these were the odds ratios for mortality. As you can see, is that as you went from a stage 1 all the way to stage 3, the mortality risk goes up. When they looked at this model and asked the questions of those patients who required renal replacement therapy, and you ask the question is, here's the stages, here's no AKI as the reference, here's AKI stage 1, stage 2, and stage 3, and if you look at the crude mortality rates based upon the distribution, there's clearly an increased hazard ratio. If you adjust this model for the presence of hyperkalemia, you have an attenuation of the model, and when you adjust it for hyperkalemia and metabolic acidosis, and then you adjust it for the fluid balance, you can see that that mortality difference is still there, the risk is still present, but has been attenuated. So in a sense, you could say the attributable mortality to these complications is quite significant, but is mostly attenuated by metabolic acid and cumulative fluid balance. So this is important, because if you think about then the emergent indications, it seems that metabolic acidosis and cumulative fluid balance are probably more a common feature and more realistic than hyperkalemia itself. Although most of us are more in tune with looking at hyperkalemia as the major risk factors, prompting us to treat these patients much more aggressively at that point in time. And when you look at this here, you can see here's hyperkalemia, here's all of these risk factors in terms of the patients receiving or not receiving RRT and complications. And the sensitivity analysis here, you can see was associated with a better hospital survival, only subgroups of hyperkalemia, metabolic acidosis, cumulative fluid balance, and azotemia. So yes, one could take home the message that, yeah, there is a reasonable amount of evidence supporting that these factors, when they are present, do contribute to risk, and therefore they need to be corrected in that setting. So why is it that we are not consistent in our approach of using these indications overall? Because if you think back to yourselves, in the last 10 patients that you've treated with renal replacement therapy, you probably will find yourself thinking that not any two of them had absolutely the same measures and the same thresholds for you to react. And that is because when we look at these patients overall, we have to consider multiple factors. So this is a very nice review article from Michael Janaitis and Louis Forney. You can see that when you look at a threshold, let's say you set yourself for blood urea nitrogen, different individuals, depending upon the catabolic rate, other factors will go on, will reach this threshold at different points in time. And when they reach this threshold at different points in time, their exposure to that target threshold has been variable over different points in time. So the exposure, therefore, becomes a variable which we don't always automatically consider or quantify as such. And this is the reason why most of the earlier studies which have looked at, say, a single biochemical parameter to say we should start dialysis doesn't tend to work as efficiently in that part. The second part is obviously when you look at creatinine values, you can see that these are influenced by volume of distribution. So unless you correct the creatinine value for the volume distribution, you may underestimate the severity and overestimate improvement in these patients itself. But the second part of this is that these parameters may not correlate with outcomes. So this is a study Marlies did and published several years ago, looking at about 1,800 ICU patients from 22 different ICUs in Germany and the UK. And what you find is when you look at the metabolic acidosis criteria, so here's less than 7.2, here's more than 7.35, look at the risk of ICU mortality goes down and increases as you go less than 7.2. Take the same criteria with respect to serum bicarbonate and you see the same trend because they are co-linked in a sense. But when you look at, say, serum potassium, you see no difference, less than 6 or greater than 6. So again, some of these variables have differentiated aspects in terms of the mortality risk, and yet they're all lumped together in the same category, saying as they're equivalent overall. A second aspect of this is that in the same study, Marlies was able to demonstrate that if you looked at those patients who received RRT before they met the creatinine criteria of stage 3, they had a better outcome than if they met the criteria of stage 3. And what she found very clearly was that this seemed to be associated much clearly with the number of organs which were failing. Now, our traditional indications for RRT do not take into account the underlying severity of illness and do not take into account the number of other organ failing. Because we are quite focused on saying is dialysis is for the kidney without necessarily thinking that dialysis is for all the organs. And therefore, that becomes an element that we are missing out in our indication-based approaches as such, as you can see the incremental risk for increased organ failure itself. A third aspect, which I think is more important, is that when we use these similar indications, we are likely to delay initiation. So this is the Finaki study, where they looked at patients who received RRT in their ICUs, and they classified them as those patients who didn't need RRT, and they took control samples from these. They found those patients who did not meet any traditional indications, called them preemptive, and then those who did and met traditional indications, they divided into two categories. In those terms of classic urgent, that they got it within 12 hours, and classic delayed more than 12 hours. And what they find here is, if you notice across there, is the time from admission. You can see this time from admission relating criteria is very short, in hours. But when you look at the time from indication to RRT start, the ones who were delayed by or started about a day later. And in this point, and you see here is, this is the number of patients who have different elements. So the incidence of hyperkalemia is not as different, but the incidence of acidosis is markedly worse in those patients who are the classic delayed. And similarly, the patients who have fluid overload, there's much more fluid overload. So again, going back to the same findings from the other studies, that fluid overload and metabolic acidosis become more a dominant factor the longer you wait, whereas hyperkalemia doesn't seem to be manifesting the same sequence overall. And when you look at the comparators here of classic RRT versus preemptive RRT, you can see the classic delayed versus classic urgent marked increase in hazard, similarly versus preemptive RRT marked increase in hazard. So what does this mean with respect to our most current study? So this study is the one from New England Journal of Medicine, and I will save most of it for Sean because I'm sure he'll be covering it. But I just want to make a point on this. So this is the study which looked at two strategies for initiating dialysis. This is a French multicenter study with 31 ICU patients included, a pragmatic trial design, where they waited for patients to have stage 3. All of them were on ventilators, all of them or required ventilator support, or were on catecholamine as an inclusion criteria requirement. And then they were randomized to an early, which means they started immediately, or that they kept them till they met a life-threatening complication later on, which is manifested by these elements here. So they had approximately 300 patients in both of these groups, well matched and balanced. They did not find a difference with respect to the mortality at 60 days, and they however found that about 50% of the people who were delayed did not need dialysis at all. But what I want to point out to you is, of the group who were early versus delayed, what you see is that there is a significant difference with respect to the creatinine, urea nitrogen, potassium, bicarbonate, and pH values, all p-values significant, in the group who are delayed. Now, there is a gap of about 50 hours between the group who starts early versus the group who starts late. Now, in that 50 hours is the time that you have able to manage their complications. And you can see here they manage the complications with diuretics, treatment of hyperkalemia and acidosis, and there was a significant increased utilization of those therapies. But what is more important is, what is the consequence of that waiting time? And that consequence of that waiting time is manifest in this Kaplan-Meier curve, but probably is better illustrated here. The 60-day mortality in these patients with those who did not eventually get dialysis was about 37. Those who got early was 48.5, and delayed was 61.8. Now, these were attenuated when you controlled for the underlying baseline severity of illness. But what it points out to you is that you do pay a price for waiting in this patient population, and therefore illustrates the fact that if you look at only traditional indications, you may not have the best opportunity to detect when you should be able to offer this dialysis in this setting. And then the last point here is that when you looked at data with non-traditional indications, as in this study where they looked at those patients who had group 1, 2, 3 were stage 1, 2, 3 of AKI, and group 4 did not meet those criteria, you actually find that the patients who were in group 4 actually had the best outcomes, and there was no creatinine increase between dialysis. Here is the standard mortality ratio. In contrast, it is much higher in these other groups here. And a similar study in a single center prospective trial where they looked at patients who were stage 3 or had akin stage 1 and 2 with compelling indications, again show you here's the traditional indications present, and you can see the ICU mortality goes from 46 to 66%, and when they are absent is 24 and 42.9%. And so this sort of trend points out to us the inability of our current indication strategies to guide what and who should be started on dialysis at that point in point. So how should you view this? One of the ways to think about it is that we need to think about all the various things which go into influencing the underlying elements. So most important is the severity of illness and trajectory. Probably the fact that you weigh in balance whether there's going to be likelihood of renal functional recovery in these patients, the risk associated with the procedures, and then also the possibility that you may be futile and the process of care and all the other elements which come into play. If you were to put all these parameters together, this is what we are doing on a daily basis intuitively. We don't have a scorecard. We don't have a way to quantify these things currently. But I think that's where we may potentially need to go to be able to say, are we measuring the same things continuously in the same manner? And therefore, one of the ways to think about it is, let me put this back in the framework I started with. Right now, we look at these indications to define whether you're going to get therapy. When we look at these indications, we are driven by the fact if there's an emergent life-threatening indication, and then more often than not, we will start very quickly if there's an urgent or a rescue medication. But it is not very often that we will be very elective, driven by goals of care. If we were to switch this around and say that our strategy should be elective goals of care in most of these patients, and urgent rescue would be more if you were not aware of the situation or missed it or it was just occurred, and we were rarely needed to do for emergent life-threatening, unless obviously the patient presents with that, then what you might be able to see is that the difference which occurs here is one of time. Because whatever led to the insult getting you to this point in time is still going on by the time you get to this point. And I think that, to my mind, is probably the most important element that we need to consider, is that it's the elapsed time. And that's not something we automatically think about, because the longer the elapsed time, the less likely you have to benefit, and the more likely you are to have futility emerge. That's what I've shown you from the data that I've shown you in my previous few slides, is one must keep in mind the time element which comes into play. So towards that end, what we've been looking at is simply doing a simple model and saying is at any given point of time, can you look at the opportunity the kidney has to handle whatever is being thrown at it? And if not, then one might need to start dialysis at an earlier time point based upon the mismatch of what is needed and what the kidney can provide at that element. But more practically, when one has this uncertainty going in, no matter how much we might be able to put this in a clear-cut, protocolized manner, there is always going to be uncertainty. And that uncertainty drives from the fact that our metrics are not always individualized. And as a consequence, therefore, you are always weighing in balance, should I not offer dialysis or should I offer it? And weighing in balance, if I offer it, will it be really beneficial or do I take it off? And that gets into this broader construct of withholding and withdrawing dialysis or any therapy. And what I have done quite often is instituted this construct of trial of therapy where you can preemptively say, I don't know what this patient is going to do over the next few days. As long as everybody is convinced that the patient is viable and we want to do something, why not offer it for a few days with full support, but with a clear-cut notion that it isn't open-ended. And in that setting, you define the goals, identify the endpoints, and get agreement from everybody that at the point of the end of that, is 3 or 4 days, you will reevaluate. If those goals have been met and improvement is there, you continue. If the goals have not been met, you either make a decision to continue forward for another trial of therapy or you discontinue. This has several advantages because it allows time to evaluate for improvement, gives family time to adjust, resolves conflict, and is somewhat an appreciable way to manage these patients itself. We've demonstrated this in this review article, which I referenced for you that you may want to look at. It goes through an algorithm of how you might want to manage these patients, and also it works through an algorithm with respect to how one might want to be able to support these patients as we go along. So finally, what I'd like to suggest to you is that what we need is individualized criteria for patient need for RRT, which is based upon not only knowledge of the present status, but what the anticipated course is going to be. We do it intuitively. But I would ask that we think about the time element. It's just going to elapse from the time you make a decision or defer a decision to the actual implementation, because that, I think, is a more important aspect. And that this trial of therapy approach should be a way to mitigate some of the risk that you have and avoid delaying this, because I think the likelihood of complications and futility increases. And I think more importantly, we need to match the modality but readjust it as the need goes on overall. And with that, I'd also like to invite you to San Diego next year to follow up on this course. Thank you for your attention.